Welcome to the Deep Dive. Today, we're tackling a topic that probably affects most people at some point. Drugs and your gut's movement.
Yeah, gastrointestinal motility. It sounds technical, but it's really just about how things move through you.
Exactly. We've got a chapter here outlining these medications, and our goal is pretty simple, really.
Just to cut through the jargon.
Right. And get to the core of how these drugs speed things up or smooth them out or even slow things down.
For conditions like constipation, diarrhea, all that fun stuff.
Think of it as, understanding the traffic signals inside your digestive system.
That's a good analogy, because when that normal rhythm gets disrupted, whether it's like a traffic jam...
Or maybe more like a runaway train.
Exactly. Different drugs step in to try and, restore some kind of order.
Okay, so broadly, what problems are we trying to fix here? First, sometimes things get backed up.
Constipation.
Yep, so we need drugs to speed things along. Then sometimes the whole system just feels, sluggish.
And some meds work to increase the overall tone in motility.
And then the opposite problem, when things are moving way too fast, like with diarrhea.
Right. Then you need drugs to slow it all down so your body can actually, absorb nutrients properly.
That sums it up well. And you mentioned that visual aid we looked at earlier. It shows how different drugs target different areas.
Yeah, it's helpful. If you picture the GI tract, some drugs, like bulk laxatives, they work right there in the lumen, in the traffic itself.
Adding more mass, basically.
Well, others, maybe like antidiarrheals, they act more on the intestinal wall, the road surface itself. It's quite a varied toolkit.
It really is. Okay, so let's start with that common traffic jam. Constipation. And that means laxatives.
Right, the go-to for many people.
And generally, these are for short-term relief, right? When you're feeling blocked up, or maybe to prevent straining.
Which is really important in certain medical situations, like after surgery or a heart attack.
Good point. And sometimes they're used just to clear everything out before a medical procedure or even after ingesting something harmful.
Definitely. But a key thing, and you see this a lot because most are over-the-counter.
You mean easy to get?
Yeah, very easy. And that leads to potential overuse. They really aren't meant for long-term, everyday use.
Because your body can get used to them.
Precisely. It can lead to what's called cathartic dependence, where your bowel almost forgets how to work on its own.
Okay, so let's look at the different types. First up, the stimulants. These sound energetic.
They are. They work by chemically irritating the lining of the GI tract. Think of drugs like Bisacodil, which is Dulcolax, or older ones like castor oil and Senna, which you might know as Senocote.
So they're literally stimulating the gut wall.
Yeah, they directly poke the nerve plexus there. That increases movement, kicks off local reflexes, usually starting in the small intestine.
And castor oil is a bit different.
A little. It also messes with fat absorption, so these stimulants offer pretty quick relief.
But that irritation factor means they're definitely not for the long haul.
Absolutely not. Really just for short-term, occasional constipation.
And how are they handled by the body?
They're minimally absorbed, so their effect is mostly local, right in the gut.
Are there times you definitely shouldn't use them?
Yes. Obvious ones are allergies, but also acute abdominal problems. Think appendicitis, diverticulitis, a bowel obstruction, ulcerative colitis. Big no-nos.
And castor oil in pregnancy.
Definitely avoid castor oil if you're pregnant. And you need to be cautious with stimulants generally if you have certain heart conditions like heart block or coronary artery disease, or if you're very debilitated.
What about just general tummy pain or nausea?
Yeah, unexplained abdominal pain, nausea, vomiting, best to check with a doctor first. Same goes for pregnancy and breastfeeding. Always use caution.
And the side effects, what can you expect?
Well, the obvious ones are diarrhea, cramping, nausea, but you might also feel dizzy, get a headache, feel weak, sometimes even sweating, palpitations, flushing, or feeling faint.
In that dependence issue we mentioned.
Right. Cathartic dependence is a real risk with long-term use. Plus, with castor oil specifically, that fat malabsorption can lead to vitamin deficiencies, especially the fat-soluble ones, and even malnutrition over time.
And drug interactions.
Always a possibility, especially if you're taking other prescribed meds. They can interfere.
Okay. You mentioned Senna as a prototype for stimulants. Quick summary.
Sure. Senna is used for short-term constipation, also sometimes for encopresis, which is fecal incontinence, usually in children.
Same mechanism, stimulating the nerves.
Yep, stimulates the nerve plexus. Mostly not absorbed. Adverse effects are pretty typical. Diarrhea, cramps, maybe some perianal irritation, dizziness, and again, that risk of dependence.
All right. Moving on to category 2, bulk forming agents. These sound less aggressive.
They are generally much gentler. Examples are methylcellulose, citrusol, polycarbophil, fibricon, and psyllium metamucil.
How do they work then, if not by irritation?
They basically add mass, add bulk to the fecal matter. Think of them like concentrated fiber.
So they increase the size of the stool.
Exactly. Which then pulls more fluid into the stool, making it softer and larger. This stimulates the stretch receptors in the bowel wall.
Which tells the bowel to get moving.
Precisely. It mimics the natural effect of dietary fiber.
Okay, so mainly for constipation. But you mentioned earlier they might help with diarrhea sometimes?
Yeah, it seems counterintuitive, but in conditions like diverticulosis or sometimes IBS, they can actually help regulate bowel function, whether it's constipation or diarrhea, by adding bulk and absorbing excess fluid.
Interesting. And their journey through the body.
They work directly in the GI tract and are generally not absorbed systemically. They can act quite rapidly for some people or might take a few days to really show an effect for others.
Any reasons to avoid these?
Again, allergy. Also, acute abdominal disorders or infections, any kind of intestinal obstruction or perforation, significant rectal bleeding, or if you're healing from recent abdominal surgery.
And side effects.
Uh,
Still possible.
oh, yeah. You can still get diarrhea, cramping, nausea. Some people might feel dizzy, weak, get headaches, sweating, palpitations, flushing. The usual suspects, though maybe less intensely than stimulants.
Is there a key takeaway for using these?
Absolutely. You must take them with plenty of water because they work by absorbing fluid. If you don't drink enough, they can actually clump up and potentially cause an obstruction.
So hydration is critical.
Very critical. And like the others, be mindful of potential interactions with other medications.
And psyllium is the prototype bulk former. Tell us about that one.
Psyllium, like Metamucil, is for occasional constipation. It also has a nice side benefit. It can help lower cholesterol levels when used as part of a heart-healthy diet.
How does it work?
Same principle. Increases bulk, draws in fluid, stimulates those stretch receptors. It's not absorbed.
Side effects.
Similar list. Potential for diarrhea, cramps, bloating is common, maybe some perianal irritation, dizziness.
Got it. Okay, third category. Osmotic laxatives. The name suggests water is involved here too.
It definitely is. Osmotics work by pulling more water into the GI tract through osmosis. They increase the concentration of solutes in the bowel.
Which draws water in from the surrounding tissues.
Exactly. It increases the fluid volume inside the bowel, which increases pressure and stimulates movement. Examples include magnesium salts like Epsom salts, magnesium citrate,
Sure.
milk of magnesia,
I know those.
and others like lactulose, polyethylene glycol, that's Mirala X, and even solutions used for bowel prep like Go Lightly.
So they're essentially hydrating the bowel contents from the inside.
That's a good way to think about it. Their main use is constipation, though some have specific indications like lactulose and liver disease.
How fast do they work?
It varies quite a bit depending on the specific drug and whether it's oral or, say, an enema.
Any major contraindications?
Don't use them if you have what's called an acute surgical abdomen, fecal impaction, or an intestinal obstruction. Lactulose specifically is contraindicated in appendicitis.
And cautions.
Be careful with lactulose if you have diabetes, because it's a sugar. Magnesium products need caution in people with kidney problems, as magnesium can build up, and polyethylene glycol warrants caution if there's a history of seizures.
Side effects for osmotics.
Diarrhea, cramping, bloating, nausea are common. Because they're manipulating fluid balance, dehydration is a definite risk.
So watch for dry mouth, dizziness.
Lightheadedness, yeah. Headache, weakness, sweating, palpitations, flushing, fainting are also possible. Rectal irritation can happen with suppositories.
And again, interactions.
Yes, they can potentially impact the absorption of other medications taken around the same time.
Okay, the prototype here is magnesium citrate. What's the story?
Magnesium citrate is often used for short-term constipation, preventing straining, bowel evacuation before procedures, sometimes to help remove ingested poisons, or even as an adjunct to flush out intestinal worms after treatment.
How does it achieve that?
By increasing fluid in the intestinal contents, which enlarges bulk and stimulates those stretch receptors. It typically works within, about 30 minutes to 4 hours.
Absorption.
So magnesium is absorbed, it varies, it binds to proteins in the blood and gets excreted by the kidneys.
Side effects for mag citrate.
Pretty standard for osmotics. Diarrhea, cramps, bloating, possibly perianal irritation, and dizziness.
All right, making good progress. Category 4, lubricants. These sound like they're greasing the wheels.
That's essentially the idea. Lubricant laxatives like Docusit, often known as Colis, glycerin suppositories, Sanisup, And mineral oil, all aim to make the stool slippery or softer, making it easier to pass.
So they don't necessarily stimulate the muscles.
Not directly, no.
Yeah.
They focus more on the stool consistency and passage. DocuSit is often called a stool softener.
How does DocuSeat work then? Is it really softening?
Well, the traditional thinking is that it acts like a detergent, reducing the surface tension of the stool and allowing water and fats to penetrate it, making it softer. But honestly, the clinical evidence supporting that mechanism strongly isn't really there. It's still widely used, often because it's perceived as having few side effects.
Interesting. What about glycerin and mineral oil?
Glycerin, usually as a suppository, acts locally in the rectum. It's hyperosmolar, drawing a little water in and gently stimulating evacuation just in that lower part. Mineral oil basically coats the stool, making it slippery.
Who benefits most from these?
They can be helpful for short-term constipation, especially when straining needs to be avoided. Think hemorrhoids, after rectal surgery, post-heart attack.
Are they absorbed?
Generally, no. They act locally and are excreted in the feces.
Contraindications and cautions.
Allergy is the main contraindication. Caution is advised with underlying abdominal disorders and, as usual, during pregnancy and lactation.
Side effects? Less intense, maybe?
Often, yes. You can still get diarrhea, cramping, nausea. Mineral oil has the specific downside of potential leakage and staining, which can be unpleasant. Dizziness, headache, weakness are less likely but possible.
Any specific warnings?
Yes, with frequent use, mineral oil can interfere with the absorption of fat-soluble vitamins A, D, E, and K. That's important.
And DocuSate is the cototype lubricant. Key points.
DocuSite is mainly used for prophylaxis, to prevent straining rather than treating existing hard stools. Also for short-term constipation relief. The supposed action is that slippery coat, less water absorption, not absorbed systemically.
Side effects for DocuSeat.
Diarrhea, cramps, bloating, potentially perianal irritation, dizziness, and like mineral oil, maybe some leakage or staining, though less common.
Okay, we've covered the main laxative types. Now, the chapter mentions something interesting. Opioid agonists for constipation relief. That sounds contradictory, doesn't it? Opioids usually cause constipation.
It does sound backwards, but it's quite clever. These drugs, like alvemopan, Entereg, methyl naltrexone bromide, Relistor, naloxegol Movantik, and naldomidine, Simproic, are designed to be selective.
Selective how?
They selectively bind to mu-opioid receptors in the periphery, specifically in the gastrointestinal tract.
So they block the opioid effects there, in the gut.
Exactly. They counteract the constipating effects of systemic opioid pain medications, the slowing motility, the reduced secretions without crossing the blood-brain barrier significantly.
So they don't interfere with the pain relief.
Generally, no. That's the goal. It allows patients to continue needed opioid therapy with less of that really bothersome constipation. Alvemopan also has a specific use post-bowel resection surgery to help hasten GI recovery.
Smart. How are they handled by the body? Pharmacokinetics.
Most are metabolized in the liver, though alvemopan is mostly metabolized right in the GI tract by gut flora. They're eliminated via kidneys and feces.
Contraindications.
Definitely should not be used if there's a known or suspected bowel obstruction. And alvemopan has a specific limitation, no more than 15 doses, due to an observed increased risk of myocardial infarction in long-term studies.
Wow. Cautions.
Use cautiously in patients with hepatic or renal impairment and during pregnancy and lactation.
And adverse effects.
Common ones include abdominal pain, diarrhea, nausea, vomiting, dizziness, flatulence, headache. It's important to monitor for signs of opioid withdrawal, although less likely with these peripheral agents, and critically, signs of GI perforation like severe, persistent abdominal pain.
Interactions.
Mainly with other opioid antagonists, using them together could increase the risk of withdrawal symptoms.
Methyl naltrexone bromide is the prototype here. What's the focus?
Right, Relistor. It's indicated for opioid-induced constipation, specifically in adults with chronic non-cancer pain.
How quickly does it work?
Peak effect is around 1.5 hours if taken orally, but only about 30 minutes if given subcutaneously. Metabolized by the liver, excreted in urine and feces, has a half-life of about 15 hours.
Side effects for this one.
Abdominal pain, diarrhea, headache, abdominal distension, vomiting, hyperhidrosis, that's excessive sweating, anxiety, muscle spasms, rhinorrhea, runny nose, hot flush, tremor, flatulence, chills. Quite a list.
It is. Before we move off laxatives completely, there were some general nursing considerations mentioned.
Yes, practical points. If using enemas or suppositories, the patient should try to retain them for as long as possible for best effect.
Makes sense.
Monitor closely for diarrhea, and if it occurs, the laxative should usually be discontinued. And really importantly, ensure the patient has easy access to bathroom facilities. It preserves dignity and prevents accidents.
Good practical advice.
Yeah.
Okay, now let's shift focus. We've talked a lot about speeding things up or easing passage. What about drugs that increase GI activity more generally?
Right. There's a class called gastrointestinal stimulants, and the main player here is metoclopramide, brand name Reglan.
How does metoclopramide work? It's not just for constipation, is it?
No, it has broader effects. It works by stimulating parasympathetic activity. Remember, that's the rest and digest system, which generally increases GI secretions and motility. It also blocks dopamine receptors centrally and peripherally.
What does blocking dopamine do here?
It seems to make the GI cells more sensitive to acetylcholine, which is a key neurotransmitter for stimulating gut movement. The net effect is more rapid movement, particularly in the upper GI tract stomach and small intestine emptying faster.
So when would you use this?
Primarily when you need to get the upper GI tract moving more quickly. It's used for symptoms of GERD, to prevent nausea and vomiting after chemotherapy or surgery, to treat diabetic gastroparesis.
Gastroparesis, that's delayed stomach emptying.
Exactly. And it can even be used to help move things along during procedures like intestinal tube placement or moving barium during radiologic exams.
How's it handled by the body?
Absorbed rapidly, metabolized in the liver, excreted in feces and urine. Importantly, it crosses the placenta and enters breast milk.
Contraindications.
Allergy, obviously. Also, GI obstruction or perforation. You don't want to stimulate movement if there's a blockage or a hole. Caution in pregnancy and lactation due to crossing barriers. Also, there's a significant boxed warning about the risk of tardive dyskinesia.
Tardive dyskinesia.
Oh, yeah.
Involuntary movements.
Yes, often of the face and limbs. It can be irreversible. So caution is needed, especially with long-term use or high doses. Also caution with history of seizures or depression.
Adverse effects beyond that.
Because it stimulates the parasympathetic system, you can see things like nausea, vomiting, diarrhea, intestinal spasms, cramping, also declining blood pressure and heart rate, weakness, fatigue. And those central nervous system effects restlessness, drowsiness, fatigue, extrapyramidal symptoms, Parkinson-like reactions, even seizures.
And drug interactions.
Big ones are alcohol and other CNS sedatives. They can increase sedation and seizure risk. Also interacts with antipsychotics and MAOIs.
So metoclopramide is the prototype. Quick recap.
Indications. GERD symptoms, preventing nausea, vomiting, post-chemosurgery. Diabetic gastroparesis, promoting GI movement for procedures. Action, stimulates upper GI motility, makes tissues sensitive to acetylcholine.
Pharmacokinetics.
Onset varies by route, peaks in 60-90 minutes orally, duration 1 to 2 hours, half-life 5 to 6 hours, liver metabolism, urine excretion.
And key adverse effects to watch for.
Restlessness, drowsiness, fatigue, those extrapyramidal effects and Parkinson-like reactions, potential seizures, nausea, diarrhea. That tardive dyskinesia risk is the big one.
Okay, important considerations there. Now let's finally hit the brakes and talk about antidiarrheals.
Right, for when things are moving too fast. The goal here is symptomatic relief, slowing down that increased motility.
How do they achieve that?
Several ways. Bismuth subsalicylate pepto-bismol seems to have a direct action on the GI lining, maybe some anti-inflammatory and antibacterial effects too.
Okay.
Crofelemer, my TC, is interesting. It blocks specific chloride channels involved in fluid secretion in the gut.
Less fluid means firmer stool.
Essentially, yes. Loperide, Imodium AD, acts directly on the muscles in the intestinal wall to slow peristalsis.
The most common one, probably.
Very common, OTC. Then you have older options like opium derivatives, like paregoric. These act more centrally but cause GI spasm and slowing as a side effect. Some anticholinergic drugs can also slow the gut, and there are combination products available too.
So, quite a few mechanisms to slow things down. What are the main uses?
Symptomatic relief of acute or chronic diarrhea, reducing the volume of discharge from ileostomies, and preventing or treating travelers' diarrhea.
Any specifics on which drug for which situation?
Bismuth subsalicylate is often used for travelers' diarrhea or diarrhea from dietary indiscretion or mild viral infections. Crofelemer has a very specific indication. Non-infectious diarrhea in adults with HIV/AIDS who are on antiretroviral therapy. Loperamide is broadly used for nonspecific diarrhea.
Pharmacokinetics vary, I assume.
Greatly, depending on the agent. Loperamide, for instance, doesn't cross the blood-brain barrier well at normal doses, which is why it doesn't typically cause the CNS effects seen with opioids.
Contraindications and cautions.
Allergy is a general contraindication. Use caution in pregnancy and lactation. Be wary if there's a history of GI obstruction, acute abdominal conditions, or if the diarrhea is caused by poisoning, you might want the poison out, not kept in. Hepatic impairment also requires caution, as many are metabolized in the liver.
What about potential downsides, adverse effects?
Since you're slowing the gut, constipation is a risk. Also, abdominal distension, discomfort, nausea, vomiting, dry mouth. A serious but rare risk is toxic megacolon, where the colon dilates massively and can perforate.
That sounds dangerous.
It is. Other effects can include fatigue, weakness, dizziness, rash, and with the opium derivative specifically, you can get lightheadedness, sedation, euphoria, hallucinations, and a respiratory depression.
Drug interactions.
Vary by agent, always worth checking.
Loperamide is the prototype antidiarrheal. Key facts.
Indications: acute to chronic non-specific diarrhea, chronic diarrhea associated with IBS, reducing ileostomy discharge. Action: inhibits peristalsis directly, slows motility, allows more time for water electrolyte absorption.
Pharmacokinetics for loperamide.
Onset varies, peak effect around 5 hours, half-life about 11 hours. Metabolized in the liver, excreted in urine and feces.
And adverse effects?
Mostly GI-related. Abdominal pain, distension, discomfort, dry mouth, nausea, constipation. Also dizziness, tiredness, drowsiness can occur.
Okay, now time for a quick quiz question from the material. True or false? Crofelemer, Mytesi, treats traveler's diarrhea by killing the bacteria that is the most common cause of the disorder.
That is false.
Why false?
Crofelemer, as we mentioned, is for non-infectious diarrhea in a specific patient population, HIV/AIDS patients on ARBs. It works by blocking chloride channels and reducing water loss, not by killing bacteria. Traveler's diarrhea is often bacterial and would need different treatment, possibly antibiotics or just supportive care depending on severity.
Good clarification.
Yeah.
All right, final section. Drugs specifically for irritable bowel syndrome, IBS, and chronic constipation. These seem targeted at more persistent issues.
Yes. IBS is incredibly common, affects more women than men, and often leads people to GI specialists. It's characterized by abdominal distress, altered bowel habits, diarrhea, constipation or alternating, plus bloating, nausea, sometimes fatigue, headache, depression, anxiety.
What's thought to cause IBS?
The exact cause isn't fully known, but it seems to involve factors like stress, alterations in gut motility, gut sensitivity, maybe changes in gut microbiota, and dysregulation of the autonomic nervous system, that gut-brain connection.
And there are specific drugs to manage these symptoms.
There are several. For IBS, depending on the predominant symptom, diarrhea or constipation, options include allosterone, Lotrenex, aloxidolene, Vibertzi, linaclotide, Linzess, lubiprostone, Amitiza, plecanatide, Trulance, tegaserod, Zelnorm, and even older drugs like hyoscyamine sometimes.
And for chronic constipation specifically?
Crucalopride, Motegrity is one approved for that.
Can you give us a quick rundown of how a few of these work? They seem quite specific.
They are. Allosterone, for example, is a serotonin 5-HT3 antagonist. It's used for severe diarrhea-predominant IBS in women who haven't responded to other therapies. It helps modulate pain signals and slow motility.
Okay. What about aloxidolene?
Aloxidolene acts on opioid receptors in the gut, mu agonist, delta antagonist, and is for adults with IBS with diarrhea.
And lubiprostone.
Lubiprostone activates specific chloride channels locally in the intestine, increasing fluid secretion. It's used for chronic idiopathic constipation, opioid-induced constipation, and IBS with constipation in adult women.
And the others. Prucalopride, tegaserod, linaclotide, plecanatide.
Prucalopride and toxerod are selective serotonin type 4, 5-HT4 receptor agonists. They stimulate colonic movement. Used for chronic constipation, and tegaserod specifically for IBS with constipation in women under 65. Linaclotide and plecanatide are guanylate cyclase C agonists. They also increase fluid secretion and speed transit, used for chronic constipation and IBS with constipation.
Quite a complex landscape. Pharmacokinetics.
Most are absorbed relatively quickly after oral administration. Metabolism varies, some hepatic, some minimal.
Contraindications and cautions.
Allergy, always. Mechanical GI obstruction is usually a contraindication for drugs that stimulate motility. Others vary, for instance. Aloxidolene has warnings regarding pancreatitis, especially in patients without a gallbladder. Allosterone has restrictions due to the risk of ischemic colitis. Pregnancy and lactation are usual cautions.
Adverse effects, mostly GI.
Yes, commonly GI symptoms like nausea, abdominal pain, diarrhea, or constipation, depending on the drug's action. But some have more serious potential effects, like the ischemic colitis with allosterone, pancreatitis with aloxitoline, or reports of new onset depression or self-harm thoughts with prucalopride and tigacerod that need monitoring.
Important warnings. Drug interactions.
Yes, for example, allosterone and aloxitoline shouldn't be used with other drugs that significantly slow GI motility due to additive effects.
Allosterone is the prototype IBS drug discussed. Key points.
Indicated only for women with severe chronic diarrhea-predominant IBS unresponsive to conventional therapy after anatomical biochemical abnormalities are excluded. It's restricted due to safety concerns.
How does it work again?
Selectively blocks 5-HT3 receptors in the gut, modulating pain, motility, and secretions.
Pharmacokinetics.
Taken orally, peaks in about an hour, short half-life of 1.5 hours, metabolized extensively by the liver, excreted by the kidneys.
Adverse effects to watch for with allosterone.
Constipation is actually the most common and can be severe. Abdominal discomfort, pain, nausea. The most serious risk is ischemic colitis, which can be life-threatening.
Okay, definitely one used under specific circumstances. We have one last multiple choice question. Why should laxatives be taken only on a short-term basis? A. To prevent a fluid volume deficit. B. To prevent cathartic dependence. C. To obtain relief of abdominal distension. D. To obtain relief of intestinal cramping.
The best answer here is B, to prevent cathartic dependence.
Explain that one more time.
Long-term use, particularly of stimulant laxatives, can make the bowel lazy or dependent on the drug to stimulate a movement. The natural muscular tone and nerve responses can diminish over time. While fluid deficit can occur with some, like osmotics, and relief of distension cramping might be a goal, the primary reason to limit duration is that risk of dependence.
Right, makes sense. Wow, this has been quite the journey through the ups and downs of GI motility drugs.
It really has. From stimulants kicking things into gear, to bulk formers adding mass, osmotics pulling in water, lubricants smoothing the way.
To the specific opioid antagonists, the general stimulant metoclopramide, the antidiarrheals hitting the brakes, and these newer targeted agents for IBS and chronic constipation.
Absolutely. It highlights how diverse the mechanisms are for addressing these really common but often quite disruptive gut issues. Understanding the differences is crucial for using them appropriately.
It really is. So for you listening, especially thinking about how easy it is to grab laxatives off the shelf, it does make you pause, right?
Are you just treating a symptom, or do you understand the underlying cause? And are you using the right tool for the job?
Exactly. Maybe this deep dive has sparked some thinking about your own digestive health and, the importance of actually talking to a doctor or pharmacist when things aren't quite right, rather than just self-treating long term.
Definitely worth considering.
Thanks for diving deep with us today.